Hello, everyone, and a very warm welcome to today's session. I'm excited to introduce our presentation titled, A Comprehensive Overview for Clinical Practice and Laboratory Diagnostics. Today, we'll be focusing on coagulation, specifically the factors and mechanisms involved in hemostasis. I'll also share some insights into how these processes are relevant in both clinical and laboratory settings. Over the course of this presentation, we'll cover the key aspects of coagulation pathways, their importance in diagnosing bleeding and clotting disorders, and how this knowledge applies to our daily practice. Thank you for being here, and I look forward to engaging with you all. So, what exactly is hemostasis? Well, hemostasis is the body's way of stopping bleeding when a blood vessel gets injured. It's a crucial process that kicks in immediately to prevent excessive blood loss. The process involves three main steps. First, vasoconstriction, where the blood vessels actually shrink to slow down blood flow right at the injury site. This helps limit blood loss initially. Next, we have platelet plug formation. Platelets, which are tiny cell fragments in the blood, stick to the injury site and form a plug. Think of it as a temporary seal to block the bleeding. Finally, we come to coagulation. This is the third step and the focus of this slide. Coagulation is where the liquid blood turns into a gel or clot, effectively sealing the wound completely. This transformation involves special proteins called coagulation factors, which work together to form a stable clot. Now, let's talk a bit about coagulation itself. It's a key part of the overall hemostasis process, but it's also a specific step. Coagulation is what makes the blood clot solidify, turning it from liquid to gel, so the wound is fully sealed and bleeding stops. To put it simply, hemostasis includes everything from blood vessel constriction to platelet plugs and finally to clot formation. But when we focus on coagulation alone, we're just looking at that final step where the clot actually forms. This step is really important because it involves a cascade of clotting proteins, coagulation factors, that work together quickly to produce a stable clot. And, interestingly, coagulation takes just a few minutes to complete, happening pretty fast so the body can respond efficiently. So, in summary, coagulation is the process that turns blood into a clot, sealing the wound and stopping bleeding completely. It's a vital and complex part of the body's defense mechanism to injury. Let's start by looking at the intrinsic pathway. This process occurs entirely inside the blood vessels. It begins when the inner wall of a blood vessel gets damaged. This damage triggers a series of reactions involving clotting factors, which are proteins in your blood. These factors are activated one after another, kind of like a chain reaction. The process involves factors XII, then XI, then IX, and finally X. This pathway is specifically triggered inside the blood vessels, and it plays a crucial role in the overall clotting process. Now, moving on to the extrinsic pathway. This one kicks in when there's external injury, like a cut on the skin. When the tissue outside the blood vessel is damaged, it releases a special protein called tissue factor, or TF. This protein quickly activates factor VII, which then activates factor XO. This pathway is primarily triggered by outside injury, and it acts faster to initiate clot formation when needed. Finally, let's talk about the common pathway, where both the intrinsic and extrinsic pathways come together. Both pathways meet at factor X. Once activated, factor X turns prothrombin into thrombin. Thrombin then converts fibrinogen into fibrin. Fibrin is what forms a mesh or net, creating a strong blood clot that seals the injury. Understanding these pathways helps us see how the body efficiently controls bleeding and maintains blood stability. The purpose of these regulatory proteins is to prevent excessive clotting and to keep our blood fluid. They act as safeguards to ensure the coagulation process doesn't go overboard. Let's start with antithrombin. It plays a crucial role by inhibiting key factors like thrombin and factor XIII, which are essential for clot formation. Without this control, clots could form unnecessarily. Next, we have proteins C and S. These work together to inactivate cofactors, such as factor V and factor VIII. By doing so, they dampen the cascade amplification. effectively slowing down or stopping the process when it's no longer needed. Plasmin is another vital player. Its job is to break down fibrin clots through a process called fibrinolysis. This helps clear clots once they've served their purpose, maintaining blood flow. Then there's the tissue factor pathway inhibitor, or TFPI. It limits the initiation of the extrinsic pathway, which is one of the main pathways that kickstarts clot formation. This regulation is critical to prevent unnecessary clotting from tissue injury signals. Protein Z also contributes by inhibiting factor XA and factor ZA, with its cofactor, ensuring these factors don't overly promote clot formation. Now, understanding these regulators isn't just academic. Their clinical significance is huge. If there's a deficiency in any of these proteins, it can lead to an increased risk of thrombosis, meaning unwanted clots can form more easily and cause problems like deep vein thrombosis or pulmonary embolism. So, in summary, the regulation of coagulation is a finely tuned system, with these key proteins acting as checks and balances. Their proper function is essential for preventing abnormal clotting and ensuring blood stays fluid when it needs to be. Let's take a closer look at the key coagulation factors by pathway. First, we have the intrinsic pathway, which is triggered by damage inside the blood vessel. Think of it as the body's internal alarm system that kicks in when something's wrong inside the vessel wall. This pathway is a bit slower because it involves several factors, starting with XII, also known as Hageman factor, then XI, or plasma thromboplastin antecedent, followed by IX, the Christmas factor, and finally VIII, which acts as a cofactor to help the process along. Moving on to the extrinsic pathway, this one is activated by external trauma, like a cut or an injury that breaches the vessel wall. It's a faster response, designed to quickly initiate clot formation. The key players here are factor III, which is tissue factor, and factor VII, also called the stable factor. Now, both these pathways converge into the common pathway, which is essentially the final steps leading to clot formation. It all starts at factor X, the Stewart-Prower factor, and then proceeds with factors V and II, which is prothrombin, leading to the production of fibrinogen. Factor I fibrinogen is converted into fibrin, stabilizing the clot, with factor XIII, the fibrin stabilizing factor, ensuring the clot holds firm. A helpful way to remember these pathways is intrinsic equals inside injury, because it starts internally. Extrinsic equals external injury, because it's triggered by outside damage. And the common pathway is the final clot formation stage. To recap, the intrinsic pathway involves factors XII, XI, IX, and VII and is slower. The extrinsic pathway involves tissue factor and factor VII and is quicker. And the common pathway begins with factor X and ends with the formation of a stable fibrin clot involving factors V, II, I, and XIII. Understanding these pathways helps us see how the body efficiently manages clot formation in different scenarios. On this slide, we're focusing on a procedure called transesophageal echocardiography, or T for short. It involves inserting a probe down the esophagus to get a much closer and clearer look at the heart. Now, because the probe is so close to the heart, T provides images that are sharper than those from transthoracic echocardiography, especially when it comes to viewing the back part of the heart. This makes it particularly useful in assessing certain conditions like atrial fibrillation, endocarditis, and congenital heart defects. However, it's important to note that T is slightly more invasive than TTE because it requires sedation, and there's a bit more preparation involved. So, while it offers more detailed images, we need to weigh that against the invasiveness and the patient's comfort. Moving on, this slide also covers clotting factors and core coagulation tests. These are essential for understanding how well your blood clots and for diagnosing bleeding or clotting disorders. Tests like prothrombin time, or PT, and INR help assess the extrinsic pathway of coagulation. The activated partial thromboplastin time, or aPTT, evaluates the intrinsic pathway. Thrombin time, or TT, measures the final step of clot formation. D-dimer is useful for detecting ongoing clot breakdown, which can be important in conditions like deep vein thrombosis or pulmonary embolism. We also look at specific proteins like protein C and protein S, which are natural anticoagulants, and coagulation factors numbered I through XIII. These include fibrinogen, prothrombin, tissue factor, calcium, and various other factors that play roles in the clotting cascade. Understanding these helps us pinpoint deficiencies or abnormalities that could lead to bleeding or clotting issues. Finally, there's the platelet function test, which evaluates how well your platelets are working in forming clots. All of these tests together give us a comprehensive picture of your coagulation status, guiding diagnosis and treatment decisions effectively. Let's take a closer look at prothrombin time, or PT, and the INR. The principle behind this test is to measure how long it takes for plasma to clot after adding a mixture of thromboplastin, which contains tissue factor and phospholipids, along with calcium. This test primarily assesses the extrinsic and common pathways of the coagulation cascade, involving factors I, V, VII, and X. A normal PT typically ranges from 9 to 13 seconds. The sample used is sodium citrate plasma blood, which is collected in a light blue cap tube. To prepare the sample, we mix about 0.3 milliliters of sodium citrate with 2.7 milliliters of blood, totaling 3 milliliters. Clinically, PT is very useful. It's often used to monitor patients on warfarin therapy, to evaluate liver function, and to diagnose bleeding disorders related to the extrinsic or common pathways. It also helps assess vitamin K status, which plays a key role in synthesizing certain clotting factors. Now, moving on to the INR, or International Normalized Ratio. The principle here is to standardize PT results across different labs, which can vary due to different reagents or equipment, by using an International Sensitivity Index, or ISI. The calculation for INR is straightforward. It's the PT of the patient divided by the PT of a control sample, then multiplied by the ISI. The normal range for INR in healthy individuals is generally between 0.8 and 1.2. Clinically, the INR is essential for ensuring consistent monitoring of patients on warfarin, with a typical target range being between 2 and 3, depending on the indication. This standardization helps us compare results accurately, regardless of where the test is performed. Let's start by understanding the PT and aPTT control. These are decided based on the MNPT and MNAPTT, which are the mean normal geometric means. Essentially, these help us establish a standard reference for our tests. The PT reference ranges are also determined using these same values, ensuring consistency. Moving on to the principles behind these tests, they can be either coagulometric or turbidimetric. These methods help us measure clotting times accurately. Now, regarding stability, the samples are stable for up to 4 hours at room temperature and up to 24 hours if stored between 2 and 8 degrees Celsius. This gives us some flexibility in handling samples. For centrifugation, the protocol is typically 4,000 RPM for 10 minutes when preparing plasma, and 2,500 RPM for 20 minutes if we're aiming for platelet-poor plasma. Proper centrifugation is crucial for accurate results. The geometric mean, or GM, refers to the patient control for each specific test. It helps us normalize the data and account for variability. When we talk about the minimum and maximum range, we're referring to the range from the lowest to the highest test value observed in the population. A critical alert value is anything above 60 seconds. If a patient's test exceeds this, it signals a potential issue that requires immediate attention. Now, how do we calculate the MNPT and MNAPTT? First, we select between 20 to 50 healthy individuals from the general population, covering all age groups and categories relevant to our practice. Then, we perform PT and aPTT tests on these samples. Using these results, we calculate the geometric mean to find our reference point. Next, we identify the minimum and maximum values from this data set. These values help define the acceptable range for our tests in clinical practice. This method ensures that our reference ranges are based on a healthy population, making our test interpretations more accurate and reliable. Let's take a closer look at the activated partial thromboplastin time, or aPTT. This test primarily measures the time it takes for fibrin to form after adding specific reagents, namely an activator, phospholipid, and calcium, to plasma. Essentially, it helps us evaluate the intrinsic and common coagulation pathways, which involve factors I, II, V, VIII, IX, XI, and XII. The normal range for aPTT is typically between 25 and 35 seconds. Clinically, the aPTT is very useful. For instance, it's commonly used to monitor unfractionated heparin therapy, ensuring patients stay within the therapeutic window. It also plays a key role in diagnosing bleeding disorders related to the intrinsic or common pathways, conditions like hemophilia A, B, or C, Factor XI deficiency, Factor XII deficiency, or von Willebrand disease. Additionally, it helps detect circulating inhibitors such as lupus anticoagulants, which can interfere with normal clotting. Now, moving on to thrombin time, or TT. This test directly measures how quickly fibrinogen is converted into fibrin after adding exogenous thrombin. It provides insight into both the quantity and functionality of fibrinogen, as well as the presence of any thrombin inhibitors. The normal range for TT is around 11.3 to 21 seconds. Clinically, TT is valuable for diagnosing fibrinogen disorders, whether they're quantitative, like low fibrinogen levels, or qualitative, meaning fibrinogen isn't functioning properly. It's also useful for detecting the presence of heparin therapy, since heparin can prolong thrombin time. Both tests are integral parts of our toolbox for understanding and diagnosing clotting abnormalities, helping us tailor patient management effectively. Now, let's take a look at some of the key coagulation tests we use to assess clotting function, starting with the PT-INR, which stands for prothrombin time and international normalized ratio. This test evaluates the extrinsic and common pathways of coagulation. It's primarily used to monitor warfarin therapy, so we look at the PT time, which normally ranges from 9 to 13 seconds, and the INR, which should be between 0.8 and 1.2 in healthy individuals. Next, we have the aPTT, or activated partial thromboplastin time. This test assesses the intrinsic and common pathways, and it's mainly used to monitor heparin therapy. The normal range here is typically 25 to 35 seconds. Moving on to the TT, or thrombin time, which falls under the common pathway. This test is often used to evaluate issues with fibrinogen, especially if there's a bleeding disorder. The normal range for TT is between 11 and 21 seconds. Finally, the D-dimer test measures fibrinolysis, basically how your body is breaking down clots. It's a useful screening tool for conditions like disseminated intravascular coagulation, or DIC, and venous thromboembolism, or VTE. A normal D-dimer level is less than 500 nanograms per milliliter. So these tests help us understand different parts of the clotting process, from formation to breakdown, and are crucial in diagnosing and managing clotting disorders. Let's start by looking at fibrinogen levels, or Factor I. This test measures the functional amount of fibrinogen in your blood, which is essential for proper clot formation. The normal range we expect to see is between 200 and 400 milligrams per deciliter. Clinically, this test helps us diagnose various fibrinogen disorders, such as afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia. It's also useful for monitoring conditions like disseminated intravascular coagulation, or DIC, which involves widespread clotting and bleeding. Additionally, assessing fibrinogen levels can help us evaluate a patient's risk for bleeding or thrombosis. Now, moving on to the D-dimer test. This test measures fibrin degradation products, which are fragments that appear when a clot is broken down. So, if there's active clot formation and breakdown happening, D-dimer levels will be elevated. The normal range is less than 500 nanograms per milliliter, or less than 0.5 milligrams per liter few. The key clinical utility of the D-dimer test is in ruling out venous thromboembolism, like deep vein thrombosis or pulmonary embolism, especially in patients who are at low to moderate risk. It has a high negative predictive value, meaning if the test is negative, it's very unlikely that the patient has a significant clot. It's also valuable for diagnosing and monitoring DIC. However, a limitation to keep in mind is that D-dimer can be elevated in many other conditions, such as infections, inflammation, or pregnancy, so it's not specific for clotting issues alone. Together, these tests give us important insights into the clotting system and help guide our clinical decisions more effectively. Let's talk about protein C and protein S, which are natural anticoagulants in our body. These are vitamin K-dependent glycoproteins, meaning their levels can be influenced by vitamin K status and medications like warfarin. Because of this dependency, testing for these proteins should ideally be done after stopping anticoagulant therapy to get accurate results. Now, how do they work? Protein C gets activated when thrombin binds to the thrombomodulin complex on endothelial cells. Once activated, called activated protein C or APC, it works together with protein S, which acts as a cofactor. This duo inactivates factor Va and factor VIA, both crucial for clot formation, thereby slowing down thrombin generation and preventing excessive clotting. When we measure these proteins, we're looking at both their quantity and their functional activity. This helps us understand how well the body's natural anticoagulant system is working. Clinically, testing these proteins is valuable for diagnosing thrombophilia, which is a predisposition to blood clots. Deficiencies in protein C or S can increase the risk of venous thromboembolism, deep vein thrombosis, or pulmonary embolism. It's especially useful in cases of unexplained clots, particularly if they occur before age 50, happen repeatedly, or are located in unusual areas. Additionally, these tests help us differentiate between inherited deficiencies, those you're born with, and acquired ones, which may develop due to other conditions or treatments. In severe inherited cases, especially in newborns, deficiencies can lead to purpura fulminans, a serious and sometimes fatal clotting disorder. So, understanding protein C and S levels gives us crucial insight into clotting risks and helps guide appropriate management. Let's start with factor I deficiency, which is also known as fibrinogen deficiency. There are actually different types, including afibrinogenemia, hypofibrinogenemia, and dysfibrinogenemia. These conditions affect the amount or function of fibrinogen, which is essential for clot formation. When testing, you'll typically see prolonged prothrombin time, or PT, prolonged activated partial thromboplastin time, aPTT, and also a prolonged thrombin time, TT. These abnormalities reflect issues in the final steps of the clotting process. Moving on to factor V deficiency, sometimes called parahemophilia. This involves a deficiency of factor V, which is part of the common pathway in coagulation. Because it impacts the common pathway, both PT and aPTT are usually prolonged in these patients. This gives us a clue about where the clotting process is disrupted. Next is factor VII deficiency. This one is a bit different because factor VII is part of the extrinsic pathway. So in deficiency, you'll see a prolonged PT, but interestingly, the aPTT remains normal. That's a key point because it helps us pinpoint the specific pathway involved. Finally, let's discuss factor VIII deficiency, which causes hemophilia A. This is an X-linked recessive disorder, meaning it mostly affects males. The deficiency of factor VIII leads to characteristic symptoms like bleeding into joints and muscles, known as hemarthroses, as well as intracranial hemorrhages and prolonged bleeding overall. When we do tests, PT tends to be normal, but aPTT is prolonged, reflecting the specific pathway affected. These clotting deficiencies, especially the hemophilias, are some of the most important disorders we need to recognize because they can significantly impact bleeding risk and management. Understanding these patterns helps us diagnose and tailor treatment effectively. Let's start with factor IX deficiency, also known as hemophilia B. This condition is caused by an X-linked recessive inheritance, meaning it primarily affects males, and it results from a deficiency of factor IX. The symptoms are quite similar to those seen in hemophilia A, including bleeding tendencies, especially into joints and muscles. When we perform coagulation tests, the prothrombin time, or PT, usually appears normal, but the activated partial thromboplastin time, or aPTT, is prolonged. This pattern helps us identify the specific deficiency. Moving on to Factor X deficiency, which involves a deficiency of Factor X, a key component of the common coagulation pathway. Since Factor X plays a central role, its deficiency impacts both the extrinsic and intrinsic pathways. In lab tests, you'll see both PT and aPTT prolonged, reflecting this broader effect on clotting. Now, let's discuss Factor XI deficiency, also known as hemophilia C. This one is inherited autosomally, so it affects both males and females equally. The symptoms can be quite variable and tend to be milder compared to other hemophilias. Patients often experience prolonged bleeding after surgeries or trauma. In terms of testing, PT remains normal, but the aPTT is prolonged, which is a common pattern for intrinsic pathway deficiencies. Finally, we have Factor XII, or Hageman factor. Interestingly, this deficiency usually doesn't cause any clinical symptoms. It's what we call a clinically silent coagulopathy. People with Factor XII deficiency are typically asymptomatic and don't have a bleeding risk. The lab pattern shows normal PT and prolonged aPTT, but this prolongation doesn't mean they are at risk of bleeding. Usually, this deficiency is found incidentally during routine screening and can be confirmed with a specific Factor XII assay. So, the key takeaway here is that a prolonged aPTT due to Factor XII deficiency doesn't translate into bleeding problems, which is an important point to remember. Let's now look at Factor XII deficiency. This condition is caused by a deficiency of Factor XII, which is also known as the fibrin stabilizing factor. Unlike other clotting factors, Factor XII's main role is to stabilize the formed clot, so if it's deficient, the clot may form but won't be stable. When testing for this deficiency, the usual coagulation tests like PT and aPTT will appear normal because those tests don't detect Factor XII deficiency. However, the clot formed in these tests might be unstable, so specific Factor XII assays are necessary to confirm the diagnosis. Moving on to platelet count, or PLT, this test measures how many platelets are present per microliter of blood. The normal range is typically between 150,000 and 450,000 platelets per microliter. If the count drops below 150,000, a condition called thrombocytopenia occurs, which increases the risk of bleeding. Conversely, if the count exceeds 450,000, we call it thrombocytosis, which can lead to a higher risk of clot formation. But it's important to remember that the function of the platelets is often more critical than just the count itself. Now, regarding platelet function tests, or PFTs, these are designed to evaluate how well the platelets are working, not just how many there are. They assess key qualitative aspects like adhesion, activation, and aggregation, which are vital to forming a stable clot. This is especially important when a patient is bleeding despite having a normal platelet count, because the problem might lie in platelet function rather than number. There are several types of these tests, including light transmission aggregometry, or LTA, the platelet function analyzer, known as PFA 100, and viscoelastic hemostatic assays like TEG or ROTEM. These tests help us get a complete picture of platelet health and function within the broader context of hemostasis. Now, let's take a look at some of the latest advancements in coagulation diagnostics that are truly transforming the field. First, we have molecular diagnostics and genetic testing. Techniques like next-generation sequencing, or NGS, allow us to analyze multiple genes at once, which significantly improves our diagnostic accuracy and precision. This means we can identify underlying genetic causes more effectively. Then there's whole exome sequencing, or WES, which is particularly useful for discovering new, previously unknown mutations that might be responsible for coagulation disorders. These tools are invaluable for making accurate diagnoses, identifying carriers, prenatal testing, and differentiating complex cases where traditional methods might fall short. Moving on, point-of-care coagulation testing is gaining ground. The biggest advantage here is speed. Results are available within minutes, which can be critical in emergency situations like acute bleeding. It also makes testing more accessible, especially in settings where lab infrastructure might be limited. Of course, there are challenges, including the dependence on operator skill, quality control issues, costs, and some limitations in test specificity that we need to manage carefully. Next, we have artificial intelligence and machine learning, which are really opening new doors. These algorithms help us interpret complex data more accurately by spotting subtle patterns that might otherwise go unnoticed. They also enable predictive analytics, allowing us to forecast risks like thrombosis, disease progression, or how a patient might respond to treatment. Additionally, AI can help ensure quality by detecting issues like clotted samples or mislabeled ones. Automation improves lab workflows and data integration, making processes more efficient. Diagnostic support systems powered by AI can even provide data-driven recommendations to guide clinical decisions. Overall, these advancements bring us closer to more accurate, faster, and personalized patient care. However, it's important to recognize the challenges, such as the risk of biased or inaccurate results, the so-called black box nature of some algorithms, data acquisition hurdles, and concerns about de-skilling laboratory personnel. As we move forward, balancing these innovations with careful oversight will be key to maximizing their benefits. Thank you so much for your time and attention. I truly appreciate your engagement throughout this presentation. Remember, the key points we've discussed highlight the importance of understanding our audience, leveraging data effectively, and applying strategic insights to achieve our goals. These concepts are at the core of our overall theme, creating impactful, informed, and innovative solutions. I hope you found this session valuable and that it inspires you to take actionable steps forward. Once again, thank you for being here and for your commitment to continuous growth and learning.